You can also write your name and roll number in the chat. You also do it on Google Forms, and please write it down here for my reference. So, should we wait for others? Only 64 are here, or should we start?
Ma'am, they'll join in 5 minutes, I think. We can wait.
Okay. Okay, let them join. Not an issue. We'll just start. Okay. So, mucogingival therapy and perioplastic surgery. So, what do you think is the difference between mucogingival surgery and perioplastic surgery? So, the topic for today is perioplastic surgery. But before that, for the historical point of view, we should know what is mucogingival therapy. So it is a general term, that is, it is an umbrella term used to describe periodontal treatment involving procedures for corrections of any defects in the morphology, position, amount of soft tissues and underlying bone around teeth as well as around implants. Okay, so this is the definition of mucogingival therapy. But what is mucogingival surgery? So to be more specific, these are the surgical procedures designed to preserve gingiva, remove aberrant frenum, muscle attachment and increase the depth of vestibule. So whenever you are asked in practical viva that what is the purpose, that why you want to do a mucogingival surgery, it can either be four of these things. You need to preserve gingiva, either you need to remove the aberrant frenum. I hope you all know what is aberrant frenum. Okay, there is a classification of frenum from normal to aberrant. So make sure you know that frenal attachment classification. Then to remove any muscle attachment. So if you have a edentulous patient who is going for a denture placement, and because of the ridge resorption, there is muscle attachment that has come over the ridge, which will unseat the denture. So in such patient, you will do a resection of the muscle attachment, okay, or you will also need increase in the depth of the vestibule. Now we'll come to what is periodontal plastic surgery. Okay, so periodontal plastic surgery, the definition is that it is surgical procedure performed to correct or eliminate anatomic, developmental, traumatic or disease-induced defects of the gingiva, alveolar mucosa or bone. Okay, mostly you are always asked definitions even if you're giving your practical viva. So make sure you give the GPT or Carranza definitions only. Okay. Now we'll see practically what all things come under periodontal plastic surgery. So these are the procedures that you can see here. It includes gingival augmentation, coverage of denuded root surface, periodontal prosthetic corrections, for crown blending, for the placement of prosthetic crowns, ridge augmentation, aesthetic corrections. Then there is reconstruction of the interdental papilla between two teeth. Then there is surgical exposure of unerupted teeth for orthodontic purposes, and there is lip repositioning. Okay. So, but what are the main objectives of periodontal plastic surgery? Why do you need to perform periodontal plastic surgery? So, as we discussed, there is either an aberrant frenum, there is a shallow vestibule, or we need to increase the width of attached gingiva. Okay, these are three basic objectives that we want to achieve. But like with the advancement in the techniques and the technology, there are few other things that we need to achieve these days. One is aesthetics, patient aesthetics. So we need aesthetic surgical correction, and next is tissue engineering. Okay. Now we'll come to the first part. So attached gingiva. So what do you think is attached gingiva? I hope you all know what is attached gingiva. Okay. So we'll not go into the detail what is attached gingiva, where is attached gingiva. Okay. Let's just assume that you know the width of attached gingiva. We will see what are the functions of attached gingiva. Why attached gingiva is so important to us that we need to preserve or increase the width of attached gingiva. It prevents the apical spread of the inflammation. Now see, if you can imagine a tooth, okay, and you have gingiva around that tooth. What is there around the CJ, neck of the tooth? We have sulcus, okay. Is sulcus tightly attached to the tooth? No, it is like a pocket, okay. So sulcus, then we have attached gingiva, which is tightly adherent to the tooth, okay. Then we have alveolar mucosa below that. So alveolar mucosa is mobile and it is non-keratinized. only attached gingiva is keratinized, okay, so that will give the tooth or the entire periodontal complex the protection that is needed, okay. So that's why attached gingiva is important. So it prevents the apical spread of inflammation, it deflects food away from the gingival margin, it braces gingiva firmly against teeth, then it acts as a buffer between two movable mucosa. Like I told you, one is alveolar mucosa, one is sulcus. Then it acts as a buffer. Okay. Then it bears the compressive and shear forces during mastication and prevents transmission of renal food. Okay. So what are the methods to measure the width of attached gingiva? This is again a part of a different seminar. So we will not go into the detail. I'll just tell you there is visual method where you can actually use only a probe and see the depth of minus the depth of the sulcus from the total gingiva. Then there is roll test. In practical exam, you will mostly all of you will be asked to perform a roll test on the patient. So either roll test is what? Using a probe, okay, the flat side of the probe, you will push the adjacent mucosa coronary, okay, with a dull instrument always, and this helps us to demarcate the mucogingival junction. So this is road test, and this is the not very common but very commonly asked question: what is a chemical method to detect the width of attached gingiva? So it is the application of Schiller's iodine or Lugol's potassium iodine solution. So what does this solution do? So what is the mechanism of action here is that your keratinized tissue, that is your attached gingiva, will not have glycogen, but your alveolar mucosa will have glycogen content. So this iodine, potassium iodine, will stain the glycogen content of the alveolar mucosa, and then you can easily demarcate it from the attached gingiva, okay, and measure the width of attached gingiva, okay. Then there is one more test called as tension test. So what is tension test? You just hold the patient's lip, lower lip, and you pull it outward, downward, and lateral direction. And you will see whether the gingival margin, okay, whether it is moving or not. If it is moving, then it said that the attached gingiva is inadequate. We are not measuring whether it is 4 mm, 3 mm, 2 mm. We'll just see whether the gingival margin is moving or it is not. If it is not, then your gingiva is inadequate. If it is moving, then your attached gingiva is inadequate. Okay? You all are there with me?
Yes, ma'am.
Yes, ma'am.
Okay, thank you. Now we will see, now there are many studies over the years that have been performed that how much mm of the attached gingiva is adequate, is like whether it is 2 mm, whether it is 3 mm, but it always varies from patient to patient. But generally, clinically, it is said that 2 mm of the attached gingiva, if it is present, it makes the patient easy to perform oral hygiene procedures. Okay, it makes him compliant, you can say, to perform the oral hygiene procedure. Okay, so there are few studies. These are not important to you. Some says it should be more than 3 mm, some say it should be less than 1 mm is also fine. If the patient can maintain his oral hygiene, then less than 1 mm is also fine. Some studies say that, okay. But what is important is Lang and Low in 1972, they stated that 2 mm is important for optimal oral health. So why do we need to increase the width of attached gingiva? So there are four factors. It enhances the plaque removal by the patient, it improves aesthetics, it reduces the inflammation, and the gingival margin binds better. Okay, so binds better around the teeth. So for these reasons, whenever there is inadequate width of attached gingiva, we need to increase the width. Now we will see how do we increase the width. We all know obviously we'll have to increase doing a surgery, a periodontal surgery, and this type of surgery is called periodontal plastic surgery. So we will now see what are the techniques that are important to increase the width of attached gingiva. There are two types of techniques, okay? They are divided into any augmentation. Augmentation is adding the gingival tissue. Any augmentation that is done apical to recession. Now see here you have to think of two different scenarios. One is recession and second is inadequate width of attached gingiva. Okay, so it is not always the case that you cannot see the root of the tooth, but still the attached gingiva might be less. In some patients this happens. So in those cases, what you do augmentation apical to the recession. Okay, so there may or may not be any recession. Okay, what you want to achieve is attached gingiva. So that's why you will do any augmentation is adding the gingival tissue apical to the margin or apical to the recession. Where we actually cover the that goes into the patient's mouth. So that category is what it is root coverage, and it is also called as any augmentation that is done coronal to the recession. Okay. Now we will see various techniques. Okay. Most commonly used over the decades is pre-gingival autograft. Okay. Then later came the pre-connective tissue autograft. Okay. And there is one more technique, that is apically reposition flap. Now remember, pre-gingival autograft, pre-connective tissue autograft can also be used to cover the denuded root surfaces. I mean for root coverage. Pre-gingival autograft, pre-connective tissue autograft can also be used for root coverage. Remember, but here what we are seeing right now is what is our aim? Our aim is not root coverage. Our aim is what? Our aim is to increase the width of attached gingiva. However, apically reposition flap. You know the third category, apically reposition flap, is only used for increasing the width of attached gingiva. If you are apically taking the flap apically downward, how can you achieve root coverage? You cannot. That's why this third technique can never be used for root coverage. Okay. Now we'll first start with pre-gingival autograft. It was given by John in 1963. So here is the technique. So this is the classical technique. Just see the pictures and try to understand. Okay. In the first picture, what you can see there is hardly 0.2 millimeters of attached gingiva. Okay, especially with the premolar region, also with the canine region, there is no attached gingiva present. So what you want to do? You want to increase the width of attached gingiva. There is no recession. You cannot say that I want to cover the root surface. No, we want to increase the attached gingiva. What you will do? First, you will create a bed. So remember these steps. You have to answer these in your Viva. Okay, most of the times. So you will create a recipient bed, connective tissue bed. Okay, why connective tissue? Connective tissue has a maximum blood supply in the region. So you need to remove the epithelial completely. We will scrape out the epithelium. Now in the picture B, your connective tissue is exposed. Okay, a good bleeding site is there. Okay, using a 15 number blade. You have to do this. Then what you will do now, you will go to the donor side. We have to increase the attached gingiva. We have to increase the gingival tissue. You will have to take that tissue from somewhere. No, you cannot just get it from outside. From patient only, you will have to take it from somewhere. So from where you will take? You will take from the palate. So palate is the best side. Other than palate, maxillary tuberosity, edentulous ridges, retromolar areas, wide zones of gingiva can also be used. Now, why palate is the best site for donor site for the gingival tissue? Because the extent of the palate, okay, the amount of the tissue that you will get is maximum in the palatal region. Okay, maxillary tuberosity will give you hardly 5 to 6 millimeters. Okay, edentulous ridge, depending on how many teeth are absent, you will get the amount of tissue. But palate will give you maximum amount of tissue. This is an additional step that you take a sterile aluminum foil, you just measure by keeping it on the recipient side, and then you take that foil back on your palate, and then you decide that how you are going to cut your tissue. Okay. Then you obtain the graft from the donor side. Now from the picture you can see how you using a 15 number blade you will remove a graft. Okay. You will not just remember. Even if I'm telling you, will not remember. You will have to read it. Okay. And if you're lucky enough, you'll be able once or in a while, then there will be a surgery in the department. You can see the surgery as well. Okay. You insert the blade into the desired thickness of one edge of the graft. Then you elevate the edge. See the difference in pre-gingival graft. Okay. Later on, we will also see connective tissue. you are removing both the things, epithelium as well as the underlying connective tissue. You are removing both of them from the palate. So what is the ideal thickness of the graft? It is 1 to 1.5. Okay. What will happen if you remove very thin layer of the graft? Okay. But what will happen if the graft is too thin? There will be necrosis and exposure of the recipient site. Okay. Your graft won't be able to protect the underlying recipient bed and it will disintegrate. Okay. And there will be necrosis. What if your graft is too thick? If your graft is too thick, there won't be good angiogenesis. What is angiogenesis? New blood vessels, those will be formed between the recipient site and the graft. They won't be enough to supply adequate amount of blood to the graft. And again, what will happen? There won't be any increase in the width of attached gingiva. Here in this picture, what you can see, the graft that we have removed from the palate, we have sutured on the recipient bed. Okay, you can just trim the graft according to your what is your need, and then you can adapt it and suture it. Now there are some precautions that you need to take. The graft must be immobilized. That is, the stability of the graft is the key for good healing. Okay, but there should not be adequate tension. Like even if I cut only 5 mm of the graft and your recipient bed is 10 mm, you cannot just stretch your graft and make it fit on the 10 mm recipient side. Okay, then you avoid trauma to the graft. Okay, immediately when you remove from the donor side, you should suture it. Okay, so don't do that you remove it from the donor side, keep it on the tray, and then you start preparing your recipient bed. No, first prepare your recipient bed and then remove the graft, and the minimum number of sutures should be given. What will happen if you suture it tightly just to achieve good stability? You suture it like 10 times at one side. What will happen? It will tear the graft. Okay, and we don't want that. And in the end, here you can see the well integrated graft of the same patient. You can see there is at least 5 to 7 mm increase in the width of attached gingiva here. And in the end, what you do, you cannot just leave the donor side just like that, because it will be a raw area, because you have removed epithelium as well. So you need to protect that donor side with a periodontal dressing. Okay. Now there are various techniques. Okay, so this was the classical technique given by John in 1963. Now there are various techniques such as accordion technique, strip technique, and the combination technique. So what is accordion technique? You will remove the graft just like classical technique, okay, from the palate. But just I told you that we cannot stretch the graft. So as accordion, you know the instrument accordion. So there are those flaps in that, okay, which can be stretched and brought back. So what you will do, you will cut your graft in such a way that a zigzag pattern is formed, okay, and then you can stretch your graft little bit, okay. It increases the donor graft tissue by changing configuration of the tissue. Then there is strip technique. The concept behind strip technique, again, the strip technique is again the same, that from palate you remove epithelium and a thin layer of connective tissue and you place it on the recipient side. But here what they say, when you need too much amount of tissue, you cannot just go on cutting the entire palate. So what they have said, instead of covering the entire recipient side with the graft, you can just take small strips from the palate and you can suture it at the most apical point of your recipient side. Okay, so as you can see here, the most apical you can place it. You can just leave the coronal area exposed, not an issue. This will also give you the increase in the width of attached gingiva. Next is a combination technique. Now combination technique is what? You will similarly, just like strip technique, you will remove a strip. Then what you will do, you will split that strip vertically. Okay, so you'll split it vertically and make it into two, and you can cover more area as compared to only strip technique or only FGG. FGG is what? Pre-gingival graft. So this is what combination technique says. Healing of the grafts, healing of the techniques we are not discussing today because it is a theoretical topic, okay? But you have to read it. It is given beautifully in Karanja as well, that how does the graft or the recipient site heals after any surgery, okay? Now, everyone will say, why unnecessarily create another donor site? Okay, if there is a material that is available synthetically that we can use instead of free gingival graft. So yes, there is another material that is a cellular dermal matrix. But again, there are various factors such as cost factor, it is expensive, the availability, okay. But a cellular dermal matrix is what? It is a non-immunogenic scaffold. Okay, it is derived from donated human skin, multi-step proprietary. So it is a patented process. Okay, so it is commercially available from the dealers. We can take the cellular dermal matrix, cut it according to our need, and place it on the recipient site. Okay, but again, the outcomes are always compared with FGG or CTG. CTG is what? Free connective tissue graft, because these are the gold standard. Okay, the healing is always better when you use the patient's own tissue, okay, or graft. Now we will talk about, so this was all about free gingival graft. Now see, the difference is I taught you free gingival graft to increase the width of attached gingiva. But later on when we will see, for root coverage, we can use the same procedure. Okay, again to increase the, to cover the root surfaces, denuded root surfaces, that we will see later. Now we'll talk about connective tissue graft. Okay. So what is free connective tissue graft? In this picture, you can see if this is the palate of the patient. Okay, can you see my pointer? Can someone please answer? Can you see the pointer?
Yes,
Someone who's awake.
Yes, ma'am. Yes, ma'am.
So here you can see the palate. Okay, this is the palate of the patient. You give a incision here. Okay, an incision is given here. You just reflect the flap. Okay, and then, oops, sorry. And then here this lime gray area is connective tissue. So here I am not removing the epithelium, I am just removing the connective tissue. I am suturing back the epithelium on the palate. This will, what this will do? This will cover my donor site. Okay, so the comorbidity with the free gingival graft is not seen with free connective tissue graft. This is the first advantage. Now I will take that connective tissue. Here in the patient you can see what are the steps. Again the steps are same. You create a recipient bed. Now here you have to remember the difference between FGG and CTG. FGG, you just remove, scrape off the epithelium entirely, because anyway from the donor side, from the palate, you are getting the epithelium that will cover the area. Here you are just taking the connective tissue from the donor side. So you will not scrape out your epithelium at the recipient side. You will just elevate a flap. Okay, you will give a partial thickness elevation. You will take aside the epithelium. Then what you will do? Okay, here you can see in these pictures what you can see how a connective tissue is seen on the palate. Okay, so this is the epithelium. This is the connective tissue. Then you suture it back after removing the connective tissue. Now I have this connective tissue graft with me. It is almost measuring how much? 10 millimeters. Okay, then I'll keep it on the recipient bed and I will suture it back. Okay, the epithelium that was elevated using a partial thickness flap, that I'll put it back on this connective tissue and I'll suture. And in the last picture, what you see is the healing. Okay, good healing is seen after 3 to 6 months. Okay. Now, like I told you, there are few advantages of CTG. First is donor site is covered. Next is what? Connective tissue carries genetic message from all-line epithelium to become keratinized. Now, what do you understand by this? So, there is better color match. Clinically, what does this mean? That epithelium will not have a color matching. If I am taking a free gingival graft from the palate, we are not sure whether the color of the palate will match the color of the gingiva in the anterior region. Okay, but with connective tissue, it will definitely happen, and there will be improved aesthetic, and there will be healing by first intention at the donor site. That was all about connective tissue. Then we will see the last technique of increasing the width of attached gingiva, that is apically reposition flap. The name itself gives us the technique. So apically reposition flap. You raise a flap, you take vertical incision so that the flap becomes mobile, and you take it towards the mucogingival junction and you suture it down. What will happen? you have sutured the flap down, the area above that flap, which is connective tissue, it will again, you will place a pad. Okay, so it will heal by secondary intention, and in the end, you will get increased rate of attached gingiva. That is. Okay, we don't have a picture. I'm sorry. Oh, sorry, we don't have a picture. I'll show you later. Okay, in the end, if we have time. So you understood the technique. Technique is very simple. Okay, normal flap is raised, which is partial thickness. It is just displaced downwards towards the apex, okay, of the tooth, or towards the mucogingival junction, and a raw eroded surface that is present coronal to the flap will again regenerate into new epithelium, okay, and you will have increased width of attached gingiva. Now we saw about all the techniques apical to the recession. Now we will see the technique coronal to recession, that means root coverage. The first part is done, attached gingiva. Now we will talk about root coverage. Root coverage can be achieved by two techniques, surgical, non-surgical, okay? Surgical and non-surgical. Non-surgical are simple techniques such as using resins, okay? It is nothing but gingival veneer we call them. We also call them pink ceramics, pink porcelains, pink composites, okay? These are available. You can just use them with your prosthetic component of the tooth, and you can give the gingiva-like appearance to the crown, okay? Then there is orthodontic management. So what you do in orthodontic management, if there is recession, what ortho will do? They will do intrusion of the tooth. Okay, so if I intrude the tooth, automatically it goes inside the bone and inside the tissue, and there will be no exposure of the root. Okay. Now this is an example, as you can see here, gingival colored composites. Here the patient has visible recession with with 1-1, and then here you can see we have just applied a pink composite, and this is the end result. Okay. Likewise, we also have gingival veneers. Now this patient has black triangle, this patient has recession, uneven gingival margin. What we make, what we do, these are veneers, but not the tooth veneers, these are gingival veneers, and we give it to the patient. So whenever patient wants to use it, he can use it. But even when we have such simple techniques, why do we still go for surgical interventions? What do you think? Because again, all these things are extra in the mouth, okay? Patient won't be comfortable. These are removable, okay? And there will be increased plaque accumulation, okay, and trauma to the tissues, okay. So there are various disadvantages. Though these are easy for us to do, but they are not good for the patient in the long run, okay. That's why we need to see various surgical techniques for root coverage, okay. So what are various techniques? So just remember this list. You have to at least know these techniques, okay. Pre-gingival graft, pre-connective tissue graft. There is pedicle graft, okay. Subepithelial connective tissue graft is similar to connective tissue graft, okay. Both are same, only the technique is different. But even if you know any one technique, that is also fine. Then there is GTR. GTR is what? You take a membrane or scaffold from outside and you place it over the tissue. Okay, you place it over the root that is exposed, and you will get root coverage. And then you have pouch and tunnel technique. Then you have pinhole surgical technique. These are the basic techniques given by whom also you have to remember. Okay, might be asked in exam. Okay, just a minute. It is 12:10. I will just take 10 minutes extra of your time if required, okay? After 12:30. So I am not discussing pre-gingival graft, pre-connective tissue graft again, because we already discussed it for increasing the width of attached gingiva. We will directly go to the pedicle graft. What is pedicle graft? Pedicle, you know what? The meaning of pedicle is what? The base of the flap or whatever. The base is always attached. Okay. Pre is what you remove from the donor side in the palate, on the palate, and then you put it somewhere else in the mouth. It is free, and pedicle is what? It is always attached. Okay. Here is the example. What you can see here in the picture is first a recipient side. There is a recession with premolar, first premolar. Okay, so we have what they have done. They have made the recipient bed ready. Okay, for the flap. Okay, for the graft, but they have not taken any graft from the palate. See what they have done. Distal to the premolar, they have given incisions. They have stretched that flap from the posterior region and brought it over the first premolar and sutured it. We have to make sure there should be minimum to no tension in the flap. Okay, whenever. So the main problem here is for a region to, like, if I have a premolar with recession, I should have adjacent teeth with adequate width of attached gingiva. So if adjacent teeth only doesn't have attached gingiva, we cannot use it as a pedicle flap. But what are the advantages? Why can we use this technique? The donor side with adequate width of attached gingiva and will do what? If my base of the flap is attached somewhere, that means there is continued blood supply. Okay, so the blood supply, the angiogenesis is not interrupted when we use pedicle flap. Okay, so in this picture you can see how it is done. Okay, here in the here there is recession on the tooth. We have given vertical incisions on the adjacent tooth, and we have just placed that flap with the base attached on the adjacent tooth with recession. Now you will say the adjacent tooth has recession. What will happen to the tooth from where we have removed the gingiva? What will happen? We have just raised a partial thickness flap. Okay. So when we raise a partial thickness flap, the underlying connective tissue is always attached and it will heal by secondary intention. So we'll get attached gingiva on both the teeth at the same time. Okay. So, but again there are disadvantages. There is incomplete root coverage. Obviously there are limitations to how much you can stretch the flap. Then there is recession in the donor area. So this is the most common disadvantage of pedicle graft, that we take the graft from the adjacent tooth, but the adjacent tooth with good attached gingiva always ends up with some amount of recession, and there needs to be adequate donor area. Adjacent to the area need to be grafted. Again, there's healing. Healing is different for pedicle, so make sure you read all the healings. Okay. Now we will talk about coronally displaced flap. So what is the gold standard of root coverage? If anyone asks you in exam what is the gold standard, you should be able to answer that coronally displaced flap or coronally advanced flap along with connective tissue graft. So I'll show you what does this technique mean. So we give two vertical incisions, okay, an internal bevel incision. Always remember, any technique that you do, be it to increase the width of attached gingiva, root coverage, root planing and scaling is the first step. Okay, if I raise a flap and I'm going to, like, I want to achieve root coverage, I cannot achieve root coverage on a root that has calculus, irregularities, infected cementum. Okay, I have to clean the root surface first. So SRB is always important. Okay, just show you the pictures. So see here what you can see, there is a recession, okay, with canine. We have done a combination here. So first we did a normal pre-gingival graft that we learned at the first. Like the first technique that we learned is pre-gingival graft. So in the second picture, what you can see, we have taken pre-gingival graft, put it on the below the root of the canine. Why? Because see, in the first picture there is no attached gingiva. Okay. And for coronally displaced flap or coronally advanced flap, it is one and the same thing. Coronally advanced flap, you should basically have attached gingiva below the recession so that you can stretch it coronally. So for that we have a gingival graft, let it heal for 3 to 6 months. Now see, in the picture C, you can see a good amount of attached gingiva around the tooth. Now I am ready to do the root coverage. So I have given vertical incision, did a partial thickness, okay, did a partial thickness, I have extended the flap coronally and sutured, okay, and this is the final healing that you can see, okay. What is the second technique? This is semilunar coronary. This is also coronary reposition flap. Okay. When our recession is very less, like it is 2 mm, okay, 2 mm or 1.5 mm, but still patient is not happy, patient wants the recession coverage. What you will do, you will give a partial, in the photo if you can see, you will give a partial thickness, you will give an incision, and using an instrument, you will just push that semilunar flap coronally. Okay. There is no need for suture for semilunar coronary reposition flap. You can just place a pad. Okay. Sometimes you can also give a suture, but it's not a mandatory thing. It was given by Tarnow. See, this is the procedure. What patient has little bit of exposure of the implant. Hello. Do one thing, no, everyone. If this meeting ends, just rejoin the meeting. Okay. I'll just end the meeting. Just rejoin.